Hello, everyone. My name is Danielle Morris, and I serve as the Health Equity Lead for the Global Social Impact Team at AWS. I am beyond excited and honored to be joined by my esteemed guest today. We are going to be talking about an important topic, health equity. All of our panelists are leading incredible work, leveraging cloud technology to advance health equity around the globe, particularly for underserved and underrepresented populations. One other theme that threads the work that they lead is that they all are being supported, or a portion of their work is being supported by the AWS Health Equity Initiative. The Health Equity Initiative is a part of AWS's $40 million 3-year commitment to support customers such as my panelists here to leverage cloud technology to advance global health equity and improve global health outcomes. So as you listen to today's conversation, I implore you not just to listen to content, but I also challenge you to listen for one lesson that you will take away to serve as an opportunity to use as a springboard to advance health equity in your own communities and organizations. So let me just give you a little bit of context about the Health Equity Initiative. We support customers, such as our panelists, to leverage cloud technology to advance health equity. We support customers who conduct a range of work, but specifically that fall under 3 areas: increasing access to health services, reducing disparities by addressing social determinants of health. And just for context, that's where a person lives, works, plays, ages. And this third is leveraging data to promote equitable and inclusive systems of care. So without further ado, I would like to introduce my guests. We have to my left, Dr. Kingsley Ndo, CEO and founder of Huron AI. We have Dr. Richard Lester, who is the co-founder of WellTel. We have Julie Stover, Chief Strategy Officer at eVisit, and Jeff Patterson, founder and CEO of Gaggle. So without further ado, I would like to invite our panelists to introduce themselves and provide a bit of an overview of the work that they lead. So Dr. Ndo, I'll start with you.
Thank you so much, Danielle, for that kind introduction. It's really an honor to be here, to see all of you come to listen to such an important topic, especially in the light of the pandemic and how we've seen health equity evolve. My name is Kingsley Ndo. I'm the founder and Chief Strategy Officer of Huron AI. And we are an early-stage digital health startup company based in Seattle, Washington. And we're on a very important mission. Before I tell you about that mission, I want to go back to Seattle, where I flew from. It was 5.5 hours. Oh my gosh, I'm still trying to get myself attuned to DC. But I want to tell you about my very good friend, Bridget Hampstead, who is the founder of CRS Sisters. She's a grandmother, an African-American grandmother. She's a 3-time breast cancer survivor. Not 1, not 2, but 3 times. You heard that right. And you know, Bridget has been very supportive of my work, and she has traveled with me, throughout Africa, to a few countries in Africa, Nigeria, Uganda, Kenya, during the course of my work in global health and cancer control. And Bridget has had firsthand view of what women face in these parts of the world, especially women like her who have had a diagnosis of breast cancer. She has also seen, the health systems there. And one day, Bridget called me and said, Kingsley, what would my fate be if I was living in any of these countries, either in Nigeria or Cameroon? And, I took a deep pause and I said, Bridget, probably you might not be here today to even ask me this question. And that's a reality of a lot of women in these low and middle income settings. Today, Bridget is thriving. She has a thriving nonprofit, Sierra Sisters with a C, and she basically helps and supports women like her to find the right doctors and cancer specialists. And this is why I want to show you what the problem is in sub-Saharan Africa. there's only one oncologist to 3,000 cancer patients. Think about that for a second. When you compare that to one oncologist to 187 cancer patients in the US, you then begin to understand the scale of the problem. What my startup is doing, and we're beta testing in Rwanda, we have our app, GoKizer, that is empowering patients to fill in those gaps that oncologists would normally fill, support patients through their treatments, perform tasks like side effects monitoring, and make them very engaged and even have an access to second opinion reviews, which is almost non-existent. And by doing this, we can help to close the African cancer data gap. Some of you will be like, what does that mean? Now, the African cancer data gap is just the fact that there's very little data about cancer of people of African descent. And so sometimes we don't even understand the full scale of the efficacy of the drugs that are being approved. We don't even understand what treatment outcomes may be, or even have targeted prevention and early detection strategies. And with wide-scale use of our app, we are hoping that we can use advanced machine learning techniques to target the most at-risk groups. Ultimately, we want to see a decrease in death toll by at least 30%. And this is why I'm very excited to have Danielle just sit beside me and the AWS team supporting Huron AI early. And hey, we're a Seattle company, why not, right? And so, so AWS is going to help us, or is helping us actually with tools for big data analysis. We can have tools for creating machine learning models, so we can have more strategic prevention and early detection, timelines for people of African descent. And we can help to have a platform to carry out clinical trials and new discovery of therapies. I don't know if you guys know this, but in the past 15 years, less than 4% of the trial participants for the cancer drugs that were approved by the FDA were actually by patients of African descent. And so what that means is we don't have a lot of data, and sometimes it might not be generalizable. So we need a platform for this, and we are working to change that. And finally, we want to also address algorithmic bias, and I don't know, I'm sure some of you in the crowd knows what I'm talking about, but a lot of the AI products today, there's growing evidence that there is algorithmic bias where clinical predictions might not be as accurate for people of African descent because the data that was used to train those predictions were mostly Caucasian data. And so I think our platform is going to help to diversify that. And more importantly, we want to create culturally sensitive solutions that are resource appropriate in the African context. Back to my story about Bridget, no one really needs to, or geography shouldn't be a determinant to live or die from cancer. It shouldn't be. And I'm working, and my team at Huron AI is working to change this. And I can't wait for the excellent Q&A and to listen to my other amazing speakers to talk about the incredible work they're doing. Thank you very much.
Greetings, everyone, and thank you, Danielle, for a wonderful opportunity to be at a fascinating tech conference. Most of the conferences I speak at are medical, so it's quite a privilege to be here. But this is really the foundation of a lot of the future, but not just in high income, but really around the world, and even in the forgotten corners of high income places. There's a lot of reach is really important. So I'm a physician in infectious diseases at the University of British Columbia, and I work in Vancouver General Hospital. But I'm also co-founder. During my postdoc, I had the fortune of working with amazing people. I went to Kenya for my postdoc during really the peak of HIV pandemic, while treatment was first being rolled out to save lives, where most people were infected, which was a real equity change. And it was a bit of a risk. People wondered, if we roll out 3 drugs that people need to take daily for the rest of their lives, Is that going to lead to non-adherence? Are they not going to take their medications? That's going to lead to drug resistance, cause more problems. Turned out that wasn't true, thankfully, and it's really been a dramatic, one of the most, the greatest humanitarian investments, I think, is the response to treating HIV globally and where people are in fact affected the most. During that time, actually, it was also the beginning of the cell phone revolution, we'll say. Already in Kenya, when we moved there, almost every 8-year-old knew how to text message. I was teaching people in Vancouver how to text message who were in their 20s, and we thought, this is an amazing way to reach out and reach people. And unlike a new startup, in some ways we're new, but in some ways we started in academia in the earliest days. We actually conducted the very first program and study, randomized trial, where we text messages to people with HIV infection, simply, how are you, or mambo in Swahili, and they could respond, sawa, I'm okay, or shida, I have a problem, and the nurse would reach them. And that alone, that simple outreach through their phones when they went back to their communities was enough to improve medication adherence. They were more likely to have undetectable virus, and therefore more likely to survive and not pass it to others. So had a dramatic effect. We published that in The Lancet in 2010, but since that time we've been working and saying, well, this is a model of care that goes well beyond HIV. And I'm going to after developing that evidence, so in medicine, we call it evidence-based medicine. We like to have evidence for the things we do to make sure our investments are going in the right direction to have the impact we hope. But we realized that studies weren't enough and we needed to reach people. So to do that, we formed a company, a nonprofit and a regular company, a social enterprise, to develop the technology that could provide a platform to provide this at scale. And our first version of that, we used to download it on computers. A lot of small communities' computers got stolen, people couldn't turn them on. So really, one of the greatest impacts for us to reach people started to become scaling with the cloud, and that's where we really made some progress in scaling through our launch on the AWS cloud. And through that scaling, to go forward, we said we can use this for TB. We're using it in maternal child health in Africa, in Kenya, Rwanda, a number of countries in Africa, South America, but in Canada too. We showed that actually the exact same method for mothers who use injection drugs and had HIV in Vancouver, Canada, just that check-in was enough to actually improve their medication adherence and HIV treatment outcomes. So now we're expanding that. I'm going to fast forward right to the current pandemic. And this is another area where we really felt the services of being able to launch securely on the cloud during a global pandemic. And we'd been doing some HIV work in Rwanda, and the Director General of the Rwanda Biomedical Center reached out and said, we need a way to support patients with COVID at home. And a lot of online tools were available, but most of the people weren't able to reach them. They said, your texting platform would be ideal. And actually, within 2 weeks, we were able to launch a program, daily texting check-ins to people in the community. They also shifted. They realized treatment centers would get quickly overwhelmed, and we need to monitor less sick people at home. And that scaled up rapidly. We did a 1-hour online session to train the people in the country, and it was really launched the next day. And it's been the backbone of their home-based care program to monitor and support patients. I'll say patients, people with COVID-19 infection. And interestingly, we use this open language, how are you type approach. We ask about symptoms, but also how are you? And a lot of the issues they had were food security. People were saying, okay, I have minimal symptoms, but I have no food. My family's at home. How do they go to school? How do I go to work? How do we get our next meal? And these are all critically important questions too. As you know, the pandemic isn't just about the infection itself. So when you have a holistic approach to patient care, which we now had, we can reach people in their, whether they were in the farm or in a small community or downtown in the city, we could equally reach them, which was really incredible. So there was over, I think, close to 100,000 patients supported, almost 18 million texts sent and received. And not a single life that we're aware of lost, actually, by supporting in the community. So I'm actually on my way to Rwanda tomorrow, so I'll also introduce you, because I'd love to stay around and talk to everyone. My partner, Dr. Gabriel Serafini, will be here to talk to anybody who wants questions after as well. And really the Health Equity Initiative has really been critical to us. I'd say there's 3 elements to me. First one is access. You need to use the tools that access people. Need to be capable, so you need to use tools that people are capable to use, and then appropriate too, and that's where, in fact, the majority of the language switched quickly from English to Kinyarwanda and being very flexible in language is part of the future too. So thank you very much.
Hi, everyone. I'm Julie Stover. I am honored to be on this panel with these folks here. I'll just tell you a little bit about eVisit to get started. eVisit is a care delivery platform for folks who are looking to engage with their healthcare consumers in more creative and innovative ways than they ever have before. And I will say that I think the pandemic certainly brought that to light. If you have been if you are in the telehealth space, I will say, or you have been in it for more than 5 minutes, I feel like you have said a time or two, this is the year, this is the year, this is the year. And sure enough, 2020 happens, and who would have thought, but that was the year. I'm excited to share with you today about a program called ET3. ET3 actually was born, if you will, prior to the pandemic. We did see a delay in the launch of the program due to COVID, but ET3 stands for Emergency Triage, Treat, and Transport. It is a CMS innovation initiative, and CMS made this available to ambulance agencies across the country. These folks have talked to you about issues with access to care in other countries. You all know we have access to care issues right here in the United States. If you can't tell by my accent, I am not from Nigeria. I live in Alabama. Alabama, with the exception of 3 counties, the entire state of Alabama is considered to be a medically underserved area, and Alabama's not unique. Those issues are in just about every state that you can think of. So what CMS did with this program is they said, we're going to offer this up to EMS agencies across the country. And the way they framed it was giving these folks the opportunity when they're dispatched through 911 to get to the scene and make what they termed as an appropriate determination of care. So what you see here is just a basic model. Obviously, it's a little more complex than this, but you get to the scene, might be the patient's home, might be their office, could be anywhere that they're dispatched to, and you determine, yes, this is a true emergency. This patient needs to go on to the emergency room. Okay, great. Transport them. You might determine that an alternative destination is appropriate. That could be a primary care clinic, urgent care, mental health facility, FQHC, you name it. Wherever is the best, most appropriate place for that patient to go. Or they might determine through their inclusion and exclusion criteria that they can do what's termed as treat in place. That's where they activate providers and they do a virtual health visit right there wherever the patient happens to be and avoid what could have been an unnecessary trip to the emergency room. You may or may not be aware that prior to this program, that if they were dispatched through 911, the only way that ambulance agencies get reimbursed for their time and the care that they've delivered is if they transport the patient to the ER. If they got to the scene and they decided that that was not appropriate for that patient and they did not transport to the ER, they are not compensated for that trip, if you will. So this is a huge advancement for CMS. This is a huge opportunity for the paramedic community and a great opportunity for us to truly, we all talk about the quadruple aim, but this truly is the quadruple aim at its finest. Here you'll see just a few of the characteristics of the model, as I referred to the quadruple aim, but it truly is person-centered care. What is the most appropriate level of care to treat that patient at that particular point in time? And their home, their office, wherever they happen to be, might just be that if they could only access a provider. Again, encouraging ensuring the appropriate utilization of services. I think what's been really exciting for me to see out of this program is that the paramedics are able to practice at the top of their license. They really enjoy this because they've been trained to treat patients in this manner. And so it's not just, they're not just a transportation company at that point. They're truly getting there, providing health care, making those choices for these patients, and then accessing the providers when and if needed. And again, just the efficiency. You know, I'm going to use some terms that you know, are a little bit unnatural for me, but I will just say, you know, there's terms you'll hear like time on the wall. It's not just about getting to the scene and treating the patients, but then you're talking about transportation time to whatever facility is the most appropriate facility, and sometimes that's not necessarily the closest. And then that's not the end of the story. They get to those facilities and they have what's called time on the wall, which means they're now sitting there waiting to offload those patients and for those patients to be admitted into those facilities. So there's a large chunk of time that those ambulances are out of commission, if you will. Well, if you live in some of those counties that I just spoke about, there might only be 1 or 2 ambulances in those counties. So when other emergencies happen, you know, there could be delays. There could be delays in dispatch. They could be having to bring ambulances from other counties to support those needs. So anytime we can use those resources more effectively and more efficiently, really everybody wins. That's when the system truly works at its finest. The last thing I would just share with you, again, I mentioned a little bit of a delay in the launch of the program. Here you'll kind of see some of the locations where we're live today. We officially started at the beginning of 2021. There are multiple counties that are represented in some of these states, but you'll just see here a little bit of the work that's been done thus far, and there's a number of others that are on tap for deployment. And we have several other customers and potential customers that are also talking about doing this work. So we're honored to be part of it, and look forward to sharing more thoughts with you all in a moment. Oh.
Thank you, Danielle, and really thank you to AWS for being such a great partner. I started Gaggle 23 years ago when I was young and naive. Gaggle started as a safe email platform for K-12 students. We're now an early warning system to identify kids in crisis before tragedy happens. I'd like to tell you a story so you can understand what we do. It's a dark story, and I apologize for that, but it turns out as best that it can. But this is the reality that our youth are living in, and I think we all need to know. One Friday evening, a boy in New Jersey, a middle school boy, pulled out his school-provided Google Chromebook, and he pulled up Google Apps and started creating a Google document. And the document said, "I'm tired of faking my feelings. I have no one who loves me, not even my family. My only choice left is suicide." So what we do at Gaggle is we sit behind the school's digital tools. We're pulling in all the email, the documents, everything the kids are creating. We have technology that highlights things that are concerning, and then a safety team that reviews these things 24 hours a day. Our safety person recognized this as a credible threat. So they called our emergency contact, who happened to be the school principal. School principal started calling home while the assistant principal called the local authorities. When the principal got a hold of the parents said, our son is fine. He's upstairs in his room. We just finished dinner. But then they went to look, and their son wasn't there. And that's why it was important that this school partnered with the local authorities, because they knew where to go. In this town in New Jersey, the trains run through on their way to New York City. And there's a spot where 2 kids had previously jumped in front of the train. They found this boy walking to that spot. It all happened in 15 minutes, and that story is so common. Last school year, that story happened over 1,400 times through Gaggle alerts. So that's what we do as our core business. What I'm excited to be partnering with AWS on is a mental health hotline for schools to provide to students, somewhere they can call and text and have a crisis counselor that will help them address some of their needs. The mental health hotline, we're still experimenting with the names, but we think we're going to call it Reach Out, and we're hoping to launch this by this fall. We just see a huge need for mental health supports for students. According to CDC, in the first summer of COVID, they surveyed 18 to 24-year-olds, and they found that 1 out of every 4 had seriously considered suicide in the previous 30 days. 1 out of every 4 of our young adults had considered suicide. That's frightening. This last summer, the CDC did some more research on emergency room visits for suicide attempts. They found that 15 to 17-year-old girls had 50% more visits to emergency room visits for suicide attempts. Our students, our young people are going through a real mental health crisis. It was going on before COVID. It's just exacerbated because of COVID. So that's Gaggle and my company, and really looking forward to the conversation here with my co-panelists.
I hope that you all are as excited as I am about this conversation, this very timely conversation about how we can disrupt old ways of doing things in order to support communities around the world who have historically been underserved and underrepresented. So you all touched on this quite a bit, and Jeff, you mentioned this, but many of the health disparities that you all discussed in your presentations were existing prior to the pandemic. How have they been amplified because of the pandemic? Julie, can you start on that one?
Yeah, absolutely. I think, what we saw during the pandemic was folks that, again, might have gone to the emergency room as their point of care. They were scared. They were scared to go to the emergency room, particularly in the early days of COVID. There were so many unknowns. And so if it was truly any of the other things, even sports-related injuries, things of that nature, they didn't want to go there and risk being infected. And so I think, while we weren't able to officially launch like I shared at the time when we thought we were going to be able to, just having that ability once we did to be able to triage folks and say, I think, we can stabilize you and you can seek treatment in these alternative locations at this point in time. You're safe to do that, was a real game changer. Again, because, during the pandemic, it just, it was just scary times, or particularly in the early days of the pandemic, very, very scary times. And many folks who normally would have sought treatment in those emergency centers didn't want to.
Jeff, can you touch on that as well?
Sure, I can share with what I saw from the school districts that we work with across the country. So many of the school districts, worked with really the most disadvantaged families, right? They were providing lunches and breakfast and the support the students need. The schools were, for many of these children, that was the safe place for them to go, where they had loving adults who cared for them, and suddenly they're torn from that system of support. The school system scrambled, first to find devices for all these students. Then they scrambled to find internet access, and they did that a variety of different ways, providing Wi-Fi hotspots. They would put internet on buses and drive it out in the community. Then they started realizing that many of these families were having food insecurity themselves. And so the school system started providing days when families could come by and pick up a box full of food to support those families, support those students. It's been really fascinating. Now, one of the negative outcomes here was, without the students being in front of these caring educators who are mandated reporters, the number of reports of child abuse went dramatically down. No one believes that child abuse dropped. It was just that there weren't adults around to find these instances.
Thank you for sharing that. So you all have set the stage for talking about health disparities and how many communities, particularly those who are underserved and underrepresented, experienced poor outcomes and over time, and particularly the pandemic compounding those. One of the things that we value at Amazon and AWS is what we call working backwards. Who's heard of that before, the working backwards process? Perfect. So essentially, it's starting with understanding what a customer or a community needs, and then working backwards from there with that understanding to then develop solutions in partnership with those communities to develop solutions that address their particular needs. If you would, each speak to how you all thought about your working backwards process. What was that like in order to develop a solution that was meaningful for the communities that you serve? Kingsley.
Yeah, thank you, Daniel, for that question. The most important person in this equation is actually the community and the individual that we serve. And one have to understand their culture, what kind of resources are available there. And for us at Huron, before we started building anything, we conducted several focus group interviews and also individual interviews. We spoke to several stakeholders in Rwanda, including the past Minister of Health, the leadership, just keep talking and understanding the landscape. And I can tell you, even in beta testing, we're still learning, because ultimately you want to align your solution to what the patient or the individual needs. You want to create a solution that is not in your head, but is something that that aligns with the community. And that's why I think with AI research and with AI applications in medicine, it really has to be resource appropriate and aligned to the culture of that community. And that's why I really love the term, in the context of what we're building, I really love the term Afrocentric. We need to build it around the people we're serving. And that's, to me, it's working backwards.
Thank you, Danielle. Yeah, and Kingsley, I couldn't agree more. At the end of the day, it's the patient or people that we're helping, whether it's the frontline providers, and that's how we started our program. We knew where we wanted to go, which was help medication adherence, but there's many, many paths to get there. So it's through those interviews. People first thought, well, maybe we'll send pill reminders every day, take your meds. Turns out that sounds good, but there's actually randomized control trials that show that doesn't change adherence. Whereas if you ask someone how you are and you engage in their problems and you help them solve them as they come up, they end up doing better. So jump ahead now to where we're trying to, from our health equity lens, is really a focus on, we've been focusing on culture. We've worked in many countries, but in Canada with First Nations communities, Indigenous communities across the country, we've had partnerships where regaining language, historical languages, has been really important. So it's something we're looking at, and there's over 6,000, I think, languages in the world. So how do we do this data science and AI that's going to help inform our projects, at the same time meeting people where they are today? I always caution we don't jump ahead to the future while leaving people behind today. So we're still texting until other means reach people faster, but we're doing a lot. So we look at this, how do we ensure, from an equity lens of language is one of our pieces we're working together, and together with Amazon through the Health Equity Initiative, we're looking at how do we scale this open language formats and partnering with others that understand language. And there is evidence, by the way, that if you get healthcare in your own native language, your first language, you're likely to have better health outcomes than if you receive healthcare in a different language. So we don't want the digital world to run ahead in English and then as an afterthought think about, oh yeah, how do we translate that? That's going to be too late. So that's one of the ways we're trying to use that approach. Thank you.
I love this question, and my answer might surprise some of you, but I will tell you, I get pretty passionate about this. I think that technology is actually the last thing that we should be thinking about when we're launching these types of programs, and I'll explain a little bit what I mean by that. But 10 plus years ago, when I really got started in the field of telehealth, I can't tell you the hospitals or health systems that I walked into and asked, are you doing telehealth? And they would say, oh yeah, we got that thing, that piece of equipment. And I said, great, can I see it? Can you show it to me? And sure enough, once they located it, a lot of times you would find it and it's blocked in by a wheelchair or an IV pole or, who knows what. And so not only are they not actively using it, but they didn't build a strategy around how and when and where and why to use it. And so even though I don't have a catchy little phrase like working backwards that I use to describe this, whenever, in my experience, whenever an operator or a physician or whoever comes to me and says, hey, we've got this flashy piece of software or hardware that we want to buy, my first reaction to them is always, time out, let's talk about what you want to do with it. And so we go through a process that we lead them through where, talk to me about what does it look like to treat this patient today, step by step by step. Break that down for me. Tell me who does what, when do they do it, why do they do it, how do they do it. Then, okay, now let's walk back through that workflow. Talk to me about all the places that you think technology is going to be inserted into this equation, and what does the utilization of that technology look like? And then talk to me about how are you going to measure that? So we know what the metrics look like, and I'll just say, typical bedside care. We know how to manage that and measure that all day long. But for some reason, the minute you start to incorporate technology in, we kind of get sideways around it, and we don't necessarily know how to measure it. And so talk to me about what success looks like. Tell me if I ask you a year from now, was this program successful? And you say, oh yeah, absolutely, that you can tell me why. It's not just anecdotal. And then when we know all of those things, we'll go find the technology to help you meet those needs and deliver care in that way. So I think it's really important to do that. Otherwise you end up with what probably looks like a really expensive coat rack or white coat rack, if you will. But I think it's really important to work backwards in that regard.
Julie, I really like that you're emphasizing not the technology, but the people and the systems. That's always the biggest challenge to really innovating, and I think you're right about that. When I think about working backwards, I think of Gaggle's, our vision statement. Our vision is that all schools are safe and all students get the mental and emotional help that they need. And I think the key to being an innovator, and everyone here is an innovator, and hopefully all y'all are too, the key to being an innovator is to asking good questions, really asking thoughtful, deep questions, and then really listening. That's what I think the real key is to being an innovator and starting with the end in mind, because then you know what the end should be based on those questions.
I really like what you and Julie touched on, and it just reminded me of the previous question, Danielle, that you asked, which was, how have the pandemic, kind of amplified things? And I remember when the pandemic started, I was being very attuned to what was happening locally in Seattle. Seattle is a hub of, infectious disease control, and, took leadership in COVID. But I was also paying attention to what African, governments were doing. And what I saw was that, and to be fair to them, people didn't really have all the data at the time to know what to do, but they were basically just repeating whatever Dr. Fauci said, lockdowns, do this, do that. And it provoked me to actually write an article in the Seattle Times, an op-ed in the Seattle Times, talking about Afrocentric responses to COVID. So thinking about it in your own context. If people are locked down, how would they, a lot of those people are daily earners. Whatever they earn, that's what they're going to eat that day. Here in the US, a lot of us have the luxury to, buy groceries for like a month. Many people in different parts of the world do not have that. So the purpose of giving you this story is to say you really have to look at it in context to find these solutions. And I like what Julie said, where you ask them what does success look like to them, and then you walk backwards and think about what are the technological solutions that are culturally sensitive to these people that I can build to accelerate to where they want to be. And I'll pass that. And by the way, it's really funny that both of us are actually traveling to Rwanda tonight. Yeah.
Thank you. So,
I mean, the panel said a lot to this one. I did want to say on the COVID previous question as well, which you kindly jumped back to as well, Kinsley. I'm an infectious disease physician, so I had more work, I'll put it that way. But one of the changes we saw when we got to work and shift towards COVID response itself, but where some of the other areas, for instance, pediatric cardiology, we're working with BC Children's Hospital and on the transplant kids. And transplant, as they become teenagers, they often lose care and they switch to adults. And they were losing kids who were not taking the medications if you don't take your heart transplant medication. So we actually found that those types of programs where we all scaled up very quickly too, just about reaching and being in touch. So we had one vision. One of the things, and I always say that to students and mentors, like you say, you need that vision where you want to be, then you'll see the other opportunities that come along the way as well. If you don't have that to begin with, you're less likely to see them. So there were a lot of offshoots as well, like helping pediatric transplant that happened during the pandemic.
So all of you all talked about an element of like relationship building and how important that is to developing and understanding where communities are and developing the solutions. Can you talk about how you all created that buy-in with the stakeholders that you worked with to develop your solutions? So, for example, Dr. Ndo, you work with the Ministry of Health in Rwanda. You work with Indigenous community councils. Julie, you work with the emergency medical communities, and then Jeff, you work with the school system. How did you create that buy-in so that they adopt technology? Many of these systems level kind of partners are oftentimes slow to adopt this new change. What was that process like for you?
Yeah, no, that's a good question. For us, I think we first looked at the National Cancer Control Plan, because you want to make sure that you're not coming with something that they're like, where are you coming from, right? So we looked at the National Cancer Control Plan, and it's clear in Rwanda's National Cancer Control Plan that they want technological solutions to a lot of the cancer control gaps. But ultimately, it's by basically engaging with the leaders, the critical stakeholders, and the Rwandan Biomedical Center, the Ministry of Health, the patients, the patient advocate groups, talking to a lot of people, gauging, the environment and just seeing, how they take your proposals. And you ultimately want them to be a champion for you or for your solution. If you don't have champions for your solution and you're pushing against a brick wall, it means you've not gotten buy-in. But really, it's just talking. Like I said earlier, I'm traveling to Rwanda. He's traveling to, just being with the critical stakeholders, and the buy-in comes in. First, trust is created, and then ultimately they see that this is value for the kind of challenges that they face in that area.
Yeah, I'll speak quickly so we can hear the other ones too. So again, healthcare, medicine tends to be evidence-based, or it should be its foundation. So doing some studies, providing good data is one of the key elements to getting buy-in. But I also found it's not enough. You also need that government engagement. You need industry mechanisms of scaling things and providing services, and that's where we're learning. But an example of alignment in working now in the U.S. with the end HIV epidemic. Unfortunately, many of you may know, HIV has been on the rise in many communities within the U.S. again as well, and many marginalized communities. And there's going to be a lot of investment forward to try and contain that. So we're working with an organization, NASDAD, that is really helping to scale services that are evidence-based interventions, and because of our trials, the WellTel intervention was an evidence-based intervention by the CDC. So being able to work then with organizations that can help navigate these systems has been quite helpful.
This question makes me laugh a little bit, and I'll tell you why. Is I kind of flash back to working in hospitals during the time when electronic medical records were coming about. And I can hear physicians in my head saying, I'm not going to use that. I will never use that. I will retire before I do that, And so I think about just the evolution of telehealth and how we've come along through this. And I'll tell you, what happened during the pandemic was it was utilized out of necessity. In many instances, we just didn't have another choice. It was the best choice. And so you saw a tremendous amount of adoption because of that. And what happened is just like with electronic medical records, physicians used it, other clinicians used it, patients used it, and now all of a sudden they liked it. And I equate it to things like having my groceries delivered to my front door during the pandemic. Well, I had never done that either, by the way, and now I wonder, why would I ever step foot in a grocery store ever again if somebody's going to bring them right to my front door? So, I think it's things like that. The way that they evolve is interesting, but when, in this program particularly, when we talk about adoption, you talk about, changing the way that folks are delivering care, and so there was a lot of dynamics at play. You had the paramedics, of course, who were not used to this. They knew in their heads, I'm just supposed to get this patient, stabilize them, take them to the emergency room. That's what I do. And so now you're telling them, hey, no, we want you to get there and make a good judgment call. So there's a little bit of hesitation there. And oh, by the way, you've got resources to support you to make that judgment call. So that's a big shift for them. You've got providers who, need to be comfortable with treating patients through technology in this manner. And so one of the things that we did is we actually started with a number of the providers that actually were serving as medical directors for these EMS agencies. So there was already a relationship there between the physicians and the medics, and so there was just a natural level of comfort. But at the end of the day, you're talking about patients, and are they willing to receive care in this manner? And the patients were absolutely given the right to decline. If they chose to go on to the emergency room because that's what they were comfortable with, then they absolutely have that right to do so. But it's also about educating them in this way, and we've seen such positive response from this program, from all parties involved. But then also you go as far as just thinking about those alternative destinations. They're not used to receiving transports from ambulances, and so they really had to change their models as well and be willing to kind of adapt. So there's a lot of training and education and buy-in that came along with that, but it's been very well received.
I would say for all of us, getting buy-in from our constituencies is about trust. Right? I think someone, maybe it was Kingsley, you said that first. It's so important, and what that means to me is to understanding our constituents' problems, what they're facing, and talking to them about it without judgment, right? No one wants to, we don't mind making mistakes, we just don't want to be judged and blamed for them. And so I think that's a key to building that trust. The school districts I work with, schools in the United States are very innovative, actually. So they're ready to embrace new things. But I think it's important that you get all the stakeholders within an organization bought into how it's going to benefit their mission, and their mission as students.
Thank you so much. I have one last question before I turn it over to the audience, because I want you to be a part of this conversation as well, this important conversation. The pandemic hit, and health equity, or the term health equity, became like the term du jour. Everybody was saying it. Every organization was trying to address it. Whereas the challenges that many of the communities that you're working with have been living, many of the challenges that they've been living with have been legacy or long-term. How do we make sure that, as we're coming out of the pandemic, health equity doesn't go away? How do we keep the momentum? If you could give the innovators in the room one piece of advice about keeping that momentum going, what would that be?
Can I start on that one?
Please, yes.
Data. You have to tell the story. And while I love a great anecdotal story, at the end of the day, when it comes to truly changing the landscape, you have to have the data to support it. And so again, doing these programs is one thing, and telling the beautiful stories that come about as a result of them is another. But truly show the data. That I would offer to you has been a challenge for telehealth for many, many years, is that, we have progressively learned how to launch these programs. We have not learned how to measure them as quickly. And so we are now doing that. And if we ever hope to see policy and legislation advance as it has during the pandemic for it to stick, we've got to have the data to tell the story.
Look, I like being data informed, but I'm a big storyteller. I think that we are emotional decision makers, and so data backs up the emotional decision that we made. That's how I see it.
Yeah, and I would just say, if you just think of it this way, almost every person on earth born has to interact with the health system at some point. So if you think about your customer, you're thinking about everybody. It doesn't matter who they are. And if we think about interventions, and we've had a discussion earlier even about sustainability, if your intervention isn't helping everybody, and it can be the executives, it can be, and often it's the same, but making sure that it actually reaches the entire population, and that includes vulnerable people, it includes everybody. And I think just that mindset itself, ask yourself, does it reach everybody?
Yeah, no, I can't agree more with what you all three have said. The only thing I'll add is paying attention to evolving trends, and it's kind of like data, right? Like, so your solution is never final. Keep looking at the data, keep tweaking, keep making sure that you're continuously serving the community, the individual, in the way they want to be served. So just never think that, oh, it's a final solution. We need to keep looking at that data as it's being used and tweaking to fit the community and the individual. Thank you.
Thank you so much. I've been in the field of public health for 17 years, and I always find opportunities to learn and be curious, but I'm particularly inspired by and motivated to do something and create meaningful change by what we've heard today. But I want to be able to, as I mentioned, turn this to you all. I want you to be a part of this conversation. So we have time for about 2 or 3 questions. Does anybody have any questions that they want to ask the panelists? 1 second, we're going to have a mic coming to you.
Thank you very much to the panelists. My name is Chinasa Imo, and I was just curious to ask, I see that across all your program, you serve the underserved communities. And when we talk about health equity, like we talk about social determinants of health, talk about biological, environmental, and then we miss sometimes the knowledge determinants of health. How do we get to these community people? If you talk about language challenge, there's education challenge, and I'm not just talking about, normal learning and education, but knowing when you are sick, what those sicknesses are, how they present, and how you are able to describe them. Because until we begin to close that gap, we will not be able to classify diseases properly, to capture them, you understand, within the data sets that will be meaningful for us to use.
I'll start to answer. So it's a tremendously important question. Thank you. And I want to hear from others, but I'll say one approach we use, and I think that's helping in the digital world, is we're going from structured to unstructured data, meaning you can say anything, do anything. And from the very first, our approach way back over a decade ago when we texted, "How are you?" the answer could be anything. The answer could be, I'm having a rash, I forgot my medication, or it could be my kid's sick, or it could be, I don't like the way you're treating me, or it could be I'm being affected by stigma. And we're starting to look, through open language formats now, and just focusing on the simple question, how are you, and letting the knowledge and language flow more naturally, I think, is going to be one of the more powerful things. But again, we still have to be conscious of how we do it. We don't want to do everything in English or everything according to 50 demographics. Being conscious of the full spectrum of everyone at the same time.
One thing I learned from you, Richard, is you said you're flexible and you have like Kinyarwanda, the local language in Rwanda, like the application translated to that. And we're definitely in the process of that because we're not doing it like in the beta trial phase yet, just because it involves money and more resources. But that's one of the things that we're definitely planning to do to sort of like fit to more of the population and include more people, because people would understand it better when it's, like you said, there was a clinical trial that showed that, when people are consulted in language, the local language, they have better outcomes. So just, doing things in a way that the local population of the vast majority of them understand, and I think we can begin to close that gap that way.
Thank you. Does anybody else have any questions? I think we have time for like one more question.
If not, Danielle, I'll jump in on that one. I think one of the beautiful things that has happened as a result of ET3 is that we know in this country that a very high percentage of folks who utilize the emergency room do that because number one, they know that they can call 911 and they can get a ride. They can utilize the ambulances as transportation. Number two, they know that the emergency room is required by law to treat them. What they don't know as often is that there are so many other community resources that are available to them. So I think one of the beautiful things that has happened through this program is as you start to think about those alternative destinations of care, they're becoming exposed to those other resources that are in their communities where they can seek treatment. And so it's, it's going to be a slow process and a continuously evolving one as more and more organizations continue to join in and participate in these programs. But I think it comes down to awareness and just, you said knowledge, but it's about that training and that education and just continuously reinforcing that there are so many others there that are available to help and to treat them, and it doesn't just begin and end in the emergency room.
So my focus is on mental health, and that's where I would be able to offer something here. And I think the important thing is that we eliminate the stigma around having mental health issues and seeking help, right? There's such a stigma about it. We need to think beyond like, oh, she's just in a bad mood, or he's just always angry. No, let's dig deeper and find out what's really going on, what is causing them to behave in these ways, and then how can we encourage them to get the help?
Thank you so much. Well, I sincerely appreciate all of the work that you all are leading across the globe to advance health equity, particularly for communities who have been left out of the conversation. And COVID-19 became the amplifier for these types of conversations, but as I mentioned to you all before, I hope that we can continue to build on the momentum that we have now so that those communities are part of the conversation, are part of developing the solution, and that technology can really serve as a mechanism for doing so. Today is, if you were just hearing about health equity today, or if you've heard about it many times before, I want to go back to that assignment that I gave you at the beginning of our conversation. Who remembers what it was? Lauren, there you go. Yes, thank you. Yes.
You want to name one thing you've learned through this panel?
Will you share that one thing, Lauren?
Sure. I didn't know that the rates for female teenagers were so high for suicide emergency room. Oh, sorry. Yeah, the thing I learned was with it regarding to mental health in teenagers and high school age girls, just how high those rates of hospital room visits, and I just found that really jarring because I'm relatively soon out of high school, so it was just really shocking.
Thank you for sharing. So Lauren got the gold star for her homework assignment. But again, this is one part of the conversation. But I hope that you all can take something that you learned today and use that as a springboard for motivating you to create that change. How are you all going to go back to your organizations on tomorrow and challenge your colleagues, challenge your ways of working, think about the communities that you serve. How are you going to work backwards to address their solutions in partnership with them and use technology as a mechanism for doing so? So thank you all so very much for joining us today in this very important conversation. And I hope that you continue to have this conversation as you go through your summit experience. Thank you.